Dear students, the topic for today's discussion is the management of undernutrition in children. I am Professor Akmal LAEEQ from the Department of Pediatrics. We have discussed in the previous lecture the subject of malnutrition, undernutrition in children, and now in the second lecture on the same topic, we will discuss its management. We have already set forth the objectives and will try to achieve them. Again, to reiterate and remind you that undernutrition presents in multiple ways. You see the patient in the top slide is malnourished. Look at the loss of subcutaneous fat and signs of wasting, like the skin is hanging loosely like an old man's skin. There is no muscle mass, very little subcutaneous fat, and it is just skin and bones. So this patient is obviously malnourished without any doubt. In the bottom picture, again you see a child maybe having a near normal weight, but he has edema all over. You can find edematous feet, legs, arms, hands, with lot of pigmentary skin changes. Pigmentation and depigmentation is quite obvious, and peeling of the skin on the shin and forearm. This is again nothing but malnutrition. Then we have undernutrition of various types that we have discussed previously. We told you that the two clinical prototypes are marasmus and kwashiorkor. Kwashiorkor manifests with edema, maybe ascites, maybe edema of the hands and feet, and growth delay and skin changes. Marasmus presents typically with weight for age falling below 60% of expected weight, but no edema. But in between these two clinical prototypes of malnutrition, undernutrition, there are conditions in which there is marasmus and kwashiorkor coexisting, like marasmus with edema. We have said that the nutritional parameters to diagnose malnutrition are basically three. The weight for age determines whether patient is underweight or not. Very simple to measure, but has lowest clinical significance. The second parameter is height for age as a result of chronic undernutrition and determines stunting. If the patient's height for age falls below -2 standard deviation. Weight for height determines presence or absence of wasting, and reflects acute undernutrition. We have discussed it in the previous lecture, and this is just a repetition. As a doctor looking after children, we should know what are the requirements for children regarding their nutrition. The caloric intake varies according to ages. Ages between 0 to 1 year, the requirement is 110 calorie per kilo per day. It decreases afterwards, and in the 1 to 3 year age group, around 100 calories per kilo per day and 90 calories per kilo per day for age group 3 to 6 years. We have another simple way, that is, for 1 year of age, it is 1000 calories, and after that you add 100 calories per year. Say 5 years old boy should have 1000 plus 500 is 1500 calories per day. Protein, a very important nutrient, and its daily intake varies age-wise. Usually is approximately 2.2 gram per kilo per day for the first 6 months of age, and then decreases to 1.5 gram per kilo per day for age group 6 months to 3 years. Among the different caloric needs and the proportion of calories supplied from the three main nutrients, as a rough estimate, carbohydrate should not provide more than 50% of the caloric intake, fats around 35% of caloric intake, and proteins around 12 to 15% of caloric intake to help adequate growth and development. Similarly, we should be knowledgeable about the various vitamins, minerals, and other micronutrients regarding their requirements for different children. Vitamin A, essential for night vision and mucosal integrity and prevention of infection. The caloric requirement is 1500 international units per day. Vitamin E, 5 to 15 milligram per day. Vitamin C, 35 milligram per day. Vitamin K, 1 milligram per day. Vitamin B1, 0.5 milligram per 1000 caloric intake. Other members of vitamin B group like niacin, 6.6 milligram, and riboflavin, 0.5 milligram per day. Vitamin B6, pyridoxine, 0.2 milligram per day. Folic acid, 0.5 to 1 milligram per day. B12, 1 to 2 milligram per day. Iron, 1 to 2 milligram per day. And we know that only 10% of iron is absorbed from the ingested amount. So in fact, we need 10 to 15 milligram of iron in the diet for 10% absorption to meet the demands. Calcium, 400 to 1200 milligram per day. Phosphate, 300 to 1200 milligram per day. Zinc, 5 to 15 milligram per day. And iodine, 50 to 150 microgram per day. This is all what we call as recommended daily allowances under the basal condition. If the patient has under stress and has a catch-up growth, he may need more, especially like a premature baby, a low birth weight baby, or baby recovering from stress, or baby having abnormal losses. These are the requirements under normal conditions. Now, the experts have designed 10 important critical steps to manage a severely malnourished child. So these 10 steps are important and they're applicable everywhere. So we'll go one by one. When a malnourished child comes to us, to a hospital, to a healthcare facility, we immediately check, treat, and prevent hypoglycemia. We check, record, treat, and prevent hypothermia. We immediately check, look for signs of dehydration, treat, and prevent dehydration. We always think of and suspect and treat or correct imbalance of electrolytes. Most of these malnourished children, they are having silent infection with few symptoms. So we have to treat, suspect, treat, and prevent infection in these babies. We have to correct micronutrient deficiencies at the very beginning to help survive. We have to start gradual, cautious, careful feeding in slowly increasing amount by whatever way patient can accept, like oral, like NG, and like other ways and means. We gradually built up the caloric intake and provide him enough calories for on a daily basis, and then we increase the caloric intake 20 to 25% above the normal for achieving the catch-up growth. Again, very important. These patients also require emotional and social support. And we also have a sensory stimulation for them in the form of adequate parental care. And finally, we prepare these children so that they are able to go home and continue the nutritional rehabilitation at home, and then ask them to come for follow-up for complete recovery. All these 10 steps are very vital. So there are different phases of nutritional rehabilitation. The first phase is called resuscitation and stabilization phase. When a sick, malnourished baby comes to a healthcare facility, these are the essential steps. Look for signs of shock, and then you have to manage accordingly by giving him oxygen, dextrose saline in a dose of 15 ml per kg over 1 hour. We don't recommend of overhydration. This can be either dextrose saline or can be Ringer lactate D. And if not available, we can use dextrose half normal saline as well. And if the patient has hypoglycemia, either on dextrose reading or clinically suspected, he can receive 10% dextrose 5 ml per kg if patient is hypoglycemic. If the patient is having severe dehydration, he should receive a modified form of ORS which is called Risomal. Risomal is ORS suitable for the needs of malnourished children. We usually restrict IV fluid. We don't give him IV fluid as for a normal, well-nourished child. But we have to add extra potassium chloride in IV fluid therapy to a dose up till 4 millimole per kg per day. These patients develop hypoglycemia very frequently, requiring 10% glucose IV as a bolus, and then frequent feeding at short intervals, small frequent feeding every 2 hours. We also need to look for, to treat and prevent hypothermia. For them, keep the babies warm by whatever means available, but the method is with a skin-to-skin contact, in close contact with the mother's body, covering the head and giving them frequent feed. This will help prevent hypothermia. If children are anemic and hemoglobin is less than 5 to 6 grams, we need to give them whole blood transfusion in small amount, 10 ml per kg, slowly over 3 hours under cover of Lasix to prevent circulatory overloading. We give them vitamin A in large doses up till 100,000 to 200,000 units stat. It will help prevent corneal ulceration and loss of vision. The dose varies, and usually 2 doses are given on the day 1 and day 2. Most children still can be saved, but very few, unfortunately, they die in the initial phase of resuscitation. And the common cause of death in them include either they had infection, which was not documented, we did not respond, or very late to start with, or they died of hypothermia, or they had fluid and electrolyte losses to the extent that baby could not cope. So these are 3 main causes of death in these malnourished children. The diarrhea is managed with Risomal. Risomal is ORS modified for the requirements of malnourished children. It contains less sodium, more sugar, more potassium than a standard ORS. It is to be given by mouth or by nasogastric tube. The amount is weight specific, like for children less than 2 years, give 50 to 100 ml after every loose stool, and for children more than 2 years, require 100 to 200 ml per loose stool. The Risomal we have been talking about, we can make Risomal in our own setup by using 1 packet of ORS for 2 liters of water. There is double dilution. We add extra sugar in it, like sucrose, 50 grams, and then we add electrolyte solution with more potassium. The sodium is almost half. The normal standard ORS has got 75 milliosmol, while Risomal has 37.5. Potassium is 40 millimole compared to 20 in standard ORS. We can add a limu in it, a lemon, squashed lemon in it, to make potassium content higher. These patients frequently have infection like pneumonia, like septicemia, but they don't have fever. So one should always suspect infection in emergency situation in these malnourished babies. We always start with broad spectrum antibiotic cover because we think that infection can be gram positive or gram negative. So we use a combination of ampicillin and gentamicin or third cephalosporin covering both gram positive and gram negative organisms. And we also use not a normal dose but a little bit higher dose to combat infection in these malnourished cases. These children, they also require micronutrients. So it is preferable to use a megadose like vitamin A given as a megadose, vitamin D as a megadose where available. The fat-soluble vitamins are stored in the liver and other body tissues and can continue their useful beneficial effect for months. Giving them daily dose frequently leads to poor compliance and unsatisfactory outcome. The requirements in these undernourished children are not equal to a well-nourished child but almost double the RDA. And we always use multiple combinations of multivitamins rather using a single vitamin giving separately. So multi-mixed preparation are always better. And this supplementation with micronutrients should be at least for 3 to 6 months and especially important in the follow-up phase. We have two specialized formulas for nutritional rehabilitation. F75 means that this formula gives 75 calories per 100 ml. This is a starter formula in initial management and beginning as soon as possible, continuing for 2 to 7 days till the patient is stabilized and taking adequate diet. Now this formula is low in protein, low in sodium, high in carbohydrate. The protein content is very low, something like 0.9 gram per 100 ml, and it provides 75 calories per 100 ml. There are certain important management steps which one should not do it. The first thing is, if a malnourished child has edema of hands and feet, do not use antibiotics to get rid of edema, but rather this edema is basically as a result of the low protein and low albumin level. So once you give them nutrition rehabilitation, edema will disappear automatically. Diuretic would worsen the situation. Initial feeding phase does not require iron therapy because it has been found that iron, when given in the first few days of nutritional therapy, is utilized by the bacteria and leads to overwhelming sepsis by bacteria. So iron therapy is usually given after 1 to 2 weeks of rehabilitation therapy. We do not use a very high protein formula to begin with, but start with a low protein formula and then in the follow-up change to high protein formula. These patients have got a very weak heart, weak body system to combat, to adjust to IV fluid if given in excess. Comparatively, oral feeding is better tolerated. So do not use IV fluid routinely for full deficit therapy, but rather only for the initial resuscitation therapy and then switch to oral rehydration therapy. The phase 2 of rehabilitation is we gradually introduce feeds. It is slowly enhancement of the feed and the calories, gradually enhanced. We start with F75 formula, which is low lactose milk, and this does provide 0.9 gram protein per 100 ml with KCl, with magnesium and minerals. In the traditional phase, 3 to 5 days, and then gradually we introduce another formula called F100 formula, because that gives 100 calories per 100 ml. The fluid requirement again increases more than what a normal child needs. It can be as high as 200 ml per kg per day, and the caloric requirement on the daily basis is again quite high, 150 to 175 calories per kilogram per day. In the recovery phase, the protein intake may be very high, something like 4 grams per kg per day, and iron may be 3 milligram per kg per day to cover up the catch-up growth. Add double RDA in the form of vitamins and minerals and micronutrients for the needs. If the baby is breastfeeding, continue breastfeeding without any break, and then we have the homemade solid food recipes are again very well suitable and tried over long time period. Another thing is RUTFF, which stands for ready to use therapeutic food. This shows you the composition of the two formulas F75 and F100 in these children. The main difference lies in the caloric content, 75 and 100, protein content, that is 0.9 and 2.9 grams, lactose, that is 1.3 low lactose and compared 4.2 grams, potassium, sodium, magnesium, zinc. All of them, they are increased, and ultimately the fat content is again quite high, and the osmolarity is again on the higher side. Again, these two formulas are supplied by UNICEF to the health department and to various nutritional rehabilitation centers where this is used. Now, for older children, another therapeutic food is RUTFF, ready to use therapeutic food given in package form. It is a mixture of powder whose composition shows peanuts for a lot of protein intake and fat intake, dried skimmed powder milk, oil, minerals and electrolytes. These children, once they are discharged, they are sent home and we can follow them in the community. They have good appetite, they can be managed at home. All do not need to be admitted. They can be advised home-based diet with different formulas which are present and which are socially more acceptable. We give them a mixed diet having combination of food in different ways. To remain healthy, especially for malnourished children, this My Plate concept has been promoted by WHO and UNICEF that the mother should be told that their child needs 4 major food items. One thing are the fruits, vegetables, grains, protein, and dairy. These are all essential components of adequate food intake by a child. Now, what should be taken? The mother education is very important. The mother should be told that among the grain, the baby can be given either rice-based food or wheat-based chapati or maize or suji or dalia. All of them are important grains for a child's growth and requirements. Fats, vegetable oils, butterfat, especially sources of fat-soluble vitamins. Proteins, the best in breast milk, followed by cow's milk or the yogurt. Minced meat, keema. Beef is essentially good. Chicken, eggs, gram seed, pulses, and peanut. If he cannot take animal protein, then still he may be able to afford the vegetable proteins like gram seed, like pulses, and like peanuts. Fruits should be given to the child's diet like banana, mango, guava, and juices. Vegetables must be added. They should be fresh, green leafy vegetables and well cooked. This shows a concept of multi-mixes, which mean it contains rice, vegetables, keema, and other things which are part of child's requirement. Well, a malnourished child can still recover. It all depends on the skills of the healthcare provider. His knowledge and skill both will decide whether the patient can recover or not. And if the patient remains under nutrition, what are the consequences? We have read already. May cause early death because of the lot of infection, lot of micronutrient deficiencies, slow learner in the school, so many adult diseases, and when he becomes adult, he remains a short-statured and underweight throughout life, and ultimately has got a low and less work output, less skilled person with less income, and unfortunately, the next generation also remains undernourished. Now, as a doctor, our important duty is to spread community education. How can we prevent it? There are essential steps, not one single, but many steps are required. Birth spacing with good weight gain, pregnancy beyond 18 years of girl's life, mother himself should have adequate nutrition during pregnancy and even after that. Mother should not be exposed to very heavy physical work during pregnancy to have good weight gain. Mother should receive micronutrient during pregnancy and lactation phase. The baby must be exclusively breastfed for 6 months and then continued for 2 years. The baby should be vaccinated properly at proper time, and baby should receive complementary food after 6 months of age. The baby should receive food from animal source, from fruit, from vegetable, from fats. All are important, but the diversity is important. There should be food mixes 5 to 6 times per day. The baby should live in an environment with good sanitation, adequate water supply, so that less infection. The parents and the children should know the importance of hand washing. During diarrhea, zinc helps in early recovery and gut recovery. Vitamin A supplementation to be taken, and then you have iodine intake and iron supplementation. nutritional monitoring advice on IMNCI should be given. Women should be educated and empowered. Of course, this is the dream of every woman to have a healthy child and a healthy mother. Thank you very much. हाँ गायब हो जाता है तुम्हारा ये किधर गया निशान किधर गया इसमें ये